This is Jerry Hesch. I work at Hesch Institute in Aurora, Colorado. And my client is a physical therapy assistant. She came to see me for treatment of her right hip. Came in limping a little bit, no longer is limping. But we are focusing now on a surgery that she had 11 years ago. She was a skater. In fact, a derby, right? Roller derby?
Yep.
Very good. I love the names they give them, but I won't say your name. Your professional name, right? But you had a spiral fracture.
Yep.
On the tibia and the fibula.
Spiral tibia, just multiple on the fibula.
Multiple on the, okay. Spiral on the tibia, the big bone, and then multiple fractures along the fibula, the outside.
Yep.
More thin bone. Okay. So she wanted me to look at her scar. And the scar extends from here to here. You can see the vertical thing where the sutures were, stitches on the lower half of it. And I've tested it in multiple directions, and the arrows in this area between, it lacks inferior motion. But right below it here, if I spring it, and I'm saying movement towards the floor, let's do that. So she's on her stomach, and if I load the lower part of the scar and pull it down towards the floor, it gets to a stop point, and then I can add a little more movement. On this side, when we take up that movement, it takes up really quickly, and then I can't get any more movement. And that's all the way up to the other arrow. But if I go in the other direction, going relatively up, then I can move it to a stop point, but I can then I can give it a little spring and it moves. Okay, the lowest part of her scar, I can load the skin and then I can spring it downward towards the heel. But if I load it and come up towards her knee, it stops very quickly. So ignore the way my finger's pointing appropriately. As soon as I push it upward, then the motion stops, okay? And I've tested the rest of the scar for, this direction and this direction. And these are the restrictions we've isolated. So I'm going to give you a very quick demonstration. And the way that I like to do what we call scar release, we can always debate language, but I'm going to go with that. The other term would be scar mobilization. We want to restore freedom of mobility. And sometimes that helps people with proprioception, interoception, how you feel in the inside of your body, even balance, and it may reduce discomfort. Do you have any discomfort around that scar?
Just, it gets really tight.
Okay, it gets really tight. I would agree with that. It's tight. Okay, so we want to restore this upward glide towards the knee of the lower aspect of the scar. So with my thumb, I push it up towards the knee, and I've done this many, many times, and that usually does not suffice. Instead, I'm going to actually move it in the free direction, which is certainly counterintuitive, okay? But I'm moderately firm, tractioning the skin downward towards the bottom of her heel. And I will typically hold that for about 3 minutes. But I think we'll just keep it down to about a minute. So bear with me, we want another 30 seconds or so, okay? And so it's called indirect scar mobilization or indirect scar release because we're moving the connective tissue into the direction of ease. That's an osteopathic concept. Lawrence Jones developed a technique called strain counterstrain, and developed that through areas throughout the body, but I don't know if it was specifically applied to scar or not. Certainly many other people are doing this. I just haven't looked into the literature and finding out who's doing this and who's teaching this, So I'm going to let go now. And we're going to retest moving that tissue up towards her knee. So I push the skin up to a stop point, and then I spring it. And there is a little bit of spring there. So I capture the skin with pressure, and then I push up to a stop point. One more time. I push up to a stop point, and then I spring it, and that's more mobile. So I'm going to go ahead and keep filming, and I'm going to capture all of this. So I think I can use the heel of my hand. Maybe not. I think I'll use my thumbs instead. And so the free direction is lifting the skin up towards the ceiling or you know, slightly, yeah, we'll go with that. Okay, I'm just lifting the skin up towards the ceiling, and that's the direction of ease. Remember, it was tight going down towards the floor. Alrighty, so bear with me. We're going to do about a minute of this. Alrighty. And what's nice is that this kind of a release seems to be long lasting. Now, when I do finish this demonstration, I will test it again. And I will also test in other directions. I'll test it in oblique directions. Did you feel anything?
Not specifically.
Okay. I thought I felt a little bit of movement. Now, that could be actual movement under my thumb, or it could also be my body accommodating to this pressure and saying, okay, we don't need to keep worrying about this. We don't need to keep reporting on it. And my sensation is altered. So it doesn't mean that her scar released, even though I felt that it did. Okay, the proof is in the pudding. You got to test it. Okay. So I'm going to go just about 15 seconds more. Okay, and so there's a lot of scar up here that was pretty free. It goes all the way up to here. All right, so I'm going to come here, and I'm going to push it down towards the floor. Okay, and that's a greater excursion. I take that to an end point. You can see the wrinkles on both sides, and then I can spring the skin, and it moves freely. And then here it does the same thing, and then here it does the same thing. So I need to do some demonstrations. It would have been nice if I had taken the time to actually try to mobilize it into the direction of restriction and see where that gets us, and then film this one. But I wanted to demonstrate the indirect treatment technique, and I proposed that the other technique would not have worked. Alrighty, so that's fibula, and that's tibia. Okay, so this is a right foot and ankle. All right, could you sit up? And I'm not going to move the camera, so we won't see your face. Can you test it? How would you test it? You're aware of it feeling tight?
Yeah, I would be standing.
Standing. So go ahead and stand up.
Oh, yeah.
Tell me.
When I'm doing this.
So she's doing an ankle stretch. Let me turn the camera to that. Okay. When you're doing a calf stretch.
That's so much better. Like now it's that front of my ankle blockage just because it's bones and not just in the back soft where tissue. It was tight.
Okay. Could you walk down the hall and back?
Yeah. That even makes my knee feel better.
Oh, I love it.
Yeah.
I love it.
Yeah, me too.
So tell me how it feels walking besides the knee.
It just feels like I'm walking, like normal.
So what did you feel before?
My foot always turns out.
Okay.
And so then feeling that up into my knee because I think that my foot.
So when you say your foot, you're talking about your right foot.
Yeah, yeah.
So the right foot turns out.
Yeah. And now it feels like it's in a regular position.
This is like wonderful.
Yeah.
Like fantastic.
So much.
Could you lay on your back?
Mm-hmm.
So we did a fair amount of work on your right hip because it had some moderate restrictions. And I was concerned, you know, like, oh my gosh, does she need hip surgery, you know? And we know that you do have two different hips. When I bend your knee up towards your chest, it goes 90 on the right and 110 on the left. And then when I do a circle with it, it's called a scour test. When I bring it up, okay, so it likes to drift outward a little bit. It's pretty happy at 11 o'clock, but, and your hip is pointing, your thigh is pointing straight up to the ceiling, and I'm gonna do a wide circle, okay? And, you know, that, of course, has not changed. And so if we do it on the other side, it's quite free. Okay, beautiful, okay? It doesn't mind coming almost straight up. It moves out a little bit. You had a distinct restriction of internal rotation. Mm-hmm. And I like to test it with a log roll. Okay? And we gained, that's a nice soft end feel. Yeah. I think that's 25 degrees.
That's so much better.
Yeah.
Like that's better even from when before you did the scar.
Yes, correct. So releasing the scar helped open up rotation of your hip. Mm-hmm. You know, certainly counterintuitive. I mean, I think the myofascial people will tell you, yeah, we say that all the time. But for many clinicians, it's counterintuitive. Mm-hmm. You know, if someone ordered PT, I don't think they would say, make sure they release your scars.
Never.
Right?
Never.
So, yeah, so there's a knowledge gap there. The other absolutely fascinating thing that happened in treating you was that we treated your internal rotation this morning, placing a 2x4x8 inch piece of foam, half round foam, under all of your hip rotators. And that technique adds a glide with some internal rotation in the hip joint, and it also compresses some muscle and tendon of every single external rotator, and we have many. And so it really relaxes them. So this morning, when I first tested you, you only went to 0. Okay, and then when I would try to spring it, it was tight. Okay? So then after we did that 5-minute technique, we gained 10 degrees. You know, and I could get a little bit of spring there. And I thought, well, you know, that's as good as it's going to get. We gained 10 more degrees. How did we gain it?
From that positioning.
Okay, let me back it up.
Okay.
I evaluated your tailbone.
Yeah.
And I found it to be rotated left.
Mm-hmm.
And I treated it. After we treated your tailbone, what happened to this rotation?
We got more. We
got 10 degrees more, so we took you to 20, and then with the scar release, we got an additional 5. And after I restored normal position and mobility of the tailbone, I then had you sit, and you felt like you were sitting straight for the first time in a long time.
Yep. And
that would certainly create an imbalance in your pelvic floor. If your tailbone is rotated, because, you know, you have part of the pelvic floor attaches the pubic bones to the coccyx, pubococcygeal muscle. What am I missing? Oh, so then when you walked, you felt like you gained pelvic rotation. So I don't think anybody would refer you for gaining hip motion and being told to, 1, be sure and mobilize the tailbone. Number two, be sure and mobilize the scar.
Yeah, no one.
Yeah. Is this counterintuitive? Well, this shows how the body functions as an integrated whole. Pieces really are connected to each other, okay? And if you look at the neurology, let me say that nerves are close by in the tailbone. The nerves are somewhat close to nerves that innervate the back of the hip. I'll say it that way. I'm not an expert in movement science. I'm not an expert in motor I'm missing a term. It's my sleep disorder. Anyway, let's skip that one. So, I mean, I would like to explore this in more detail, and I will. But the bottom line, by making it simple and not throwing a bunch of fancy terminology, the body's an integrated unit. And by screening the entire body, then we have a potential to really help our clients more than just focusing on the main problem. So that's all I'm going to say. And in the next 10 minutes, I'm going to teach you simple things you can do at home. Do them twice a week, and it will be very easy for you to maintain these gains. And when you walked in yesterday limping, I thought, you know, and then when I looked at your hip, I'm thinking, oh dear, you know, we might need some surgical intervention. So the gain in your motion truly did surprise me, because I've had other people and they have significant OA and that motion's not gained. So it was a great surprise, and I'm delighted. Thank you.